And I was so delighted when Keris Jan Myrick accepted the Conference Planning Committee's invitation to be this year's honoree. I've known her for years. I've known of her for years. First, as the most compelling face and voice in the NAMI In Our Own Voice training video. Then in 2015, I introduced myself to her following her keynote speech at the ISPS International Congress in New York City. And just this past year, Keris and I had an opportunity to share space as part of the Yale Program for Recovery and Community Health's Lived Wisdom group with Yale postdoc Anna Florence and her mentor, Dr. Larry Davidson. The bi-weekly Lived Wisdom meetings began shortly after the pandemic sent us all to virtual spaces and resulted in a series of podcasts and webinars, and ultimately an article that was published in Psychosis in 2020. Especially because the pandemic brought to the fore increasing acknowledgement of the ways in which people of color, and especially Black people, were being far more greatly harmed by the pandemic. Keris's experience, gravitas, voice, and considerable grace were and are extraordinarily compelling. This is part of her official bio. Keris Jan Myrick is director of a leading mental health advocate and an executive known for her innovative and inclusive approach to mental health reform and the public disclosure of her personal story. Currently, she is director of the Adhd Foundation and co-director of the Mental Health Strategic Impact Initiative, which aims to advance the transformation of mental health by catalyzing cross-sectional reforms, strengthening collaborations, and bridging gaps. She serves on the board of the National Association of Peer Specialists and is a certified personal medicine coach. She is also a former director of the Office of Consumer Affairs for the Center of Mental Health Services of the U.S. Health and Human Services Substance Abuse and Mental Health Services Administration, or SAMHSA. Keris's topic this morning is Silence Me Not, the Power of Words to Break the Chains of Mental Health Oppression. Keris, welcome.
Thank you so much, Claire. What a lovely introduction. It's really early, so you might hear me do a lot of umming, but for the most part, I'm very excited and very awake. I have my coffee, I have my water, I have my dog. All is good. So I'm going to go through some slides. You will have access to these slides after the presentation. But before I kick off, let me go ahead and give you a visual description of myself. I'm African-American. I'm also Muskogee Creek. I'm a member of that nation. I have long Black hair. I'm wearing Black glasses. I'm wearing a black and white sweater with a button that says good trouble, necessary trouble. Okay, so let me go ahead and share my slides. And again, thank you so much for having me this morning. I'm really excited to be here. Okay, let's see if this works. Did it work? Since I can't see anybody. Okay, so, and because I can't see anybody, this is so curious to do it this way. I'm very interactive. I kind of need to see people. So I might ask you to put stuff in the chat just so that I know that I'm not talking to myself, which is something I can do often, but kind of don't want to do it during a keynote, I don't think. So we're going to talk about Silence Me Not, the Power of Words to Break the Chains of Mental Health Oppression. When I first started doing this presentation, when I started working on the slides, I had one set of slides, and literally something happened in the last couple of weeks that the slides sort of morphed into something else. I tried to meet the learning objectives nonetheless, but sometimes that's how life happens, I guess. So you all heard a little bit, and you all can say, this is cute. Just go ahead and do it. Put it in the chat. Go ahead and say, aw, or aw. Okay, so what I want you to know about me is that I am, all the things that was said in the bio, but I'm also a sister. There's my brother. My mother says, "Oh, he loves you so much. Look at him kissing you." And I'm like, "No, I think he's sucking the life out of me, Mom." I'm a daughter, a granddaughter, cousin. As I said, I'm African American. I'm a member of the Muskogee Creek Nation. I'm an Army brat, or what I like to call a global nomad. That picture actually was taken in Bremerhaven, Germany, where I was born. But most importantly, I'm a human. A lot of people already know I have lived experience of a mental health condition, but I am a human. And of course, I'm a person. Look at him. What is my brother doing? Now he's trying to squeeze the life out of me. I don't understand it, but actually we do get along. I can't wait until we can take an adult picture of us. Have you seen those pictures where people get together and they take the same picture they were when they were kids? So this is sort of me as a person. And I'm going to talk a lot and use language sometimes that we may not be comfortable, especially in this space, using. But I want people to hear how I'm using the language, because I use it really with intention. So as Pat Deegan says, many people are so uncomfortable with the stigma associated with mental illness that they would rather suffer in silence than get the help that they need. And this is particularly true for people given a diagnosis of schizophrenia. And I was one of those people that was given a diagnosis of schizophrenia. And I need you to hear what I said. I said I was given a diagnosis of schizophrenia. I don't say I have it. I don't say I live with, I don't say any of that, because the fact is I was given this diagnosis. This has gotten me in trouble a lot of times because I'll use the language that was given to me, and people may perceive that somehow I have a very medicalized understanding of what's happened to me. But what I'm trying to actually say is that this is what happened to me. I was given a diagnosis. I didn't say I took it. I said I was given it. And when I was given that diagnosis, I had no understanding of quite what was going on. I was afraid to tell anybody what was going on. And I actually felt like this song from the Smiths. I know I'm unlovable. You don't have to tell me. Oh, message received loud and clear, but I don't have much in my life. Take it. It's yours. And that's the way I felt about my life. That's the way I felt about not even, telling my parents much what was going on. And when I was given the diagnosis, so many things were important to me. I was talking about the fact that I had to stop school, that I was struggling with keeping up with school and reading the assignments. I also was working at the time, and I had to stop work. And those were the things that I kept talking about. But at the time, everybody wanted to focus on the mental illness and the professional care. All of the things that were important to my life, important to me, were shoved off to the side while everybody tried to do this thing called get those symptoms down. Ron Unger has a great article. I don't remember where I read it. And he was talking about a fire hose, and that when you're in crisis or having your symptoms or whatever you want to call them are kind of in front of everybody, everybody just wants them to stop. And that's kind of what was going on. But what I wanted really was not about the stopping of the symptoms per se, but I wanted the ongoing and the importance of my life. So this is sort of what changed what I was going to do today a little bit, is Jess Stolman Rainey had sent out this tweet, and it was sort of a series of tweets, but it started off, #Ableist Therapy, is when a social worker told me I should get used to the idea that I'd never go to college, live on my own, or hold a job after I was diagnosed with schizophrenia. And I don't know why I was struck by this, other than that's exactly what I was told by a psychiatrist and also by a psychologist. But for me, I think, and for other people of color, especially African Americans, Black and brown folks, this is what I'd been told out of the womb about all of the things that I wouldn't be able to do, that in no way did I have the intelligence to go to college. In no way would I have a job other than a job, a sort of menial job, if you will. So when I was diagnosed with schizophrenia, I was told the very same thing. And I thought, wait, what's going on here? So not only is this ableist, but it's also sanist. It's also racist. And I don't know that people kind of wrap their head around the fact that people of color, particularly African American and Black and brown folks, these are the messages we hear all our life. So when I guess I was talking about those things that were important to me in the circle, it may not have just been about the diagnoses that people were saying I couldn't do it. It may have also been because I'm Black. It may have also been because I'm a woman. And that becomes really hard and very tiring to figure out. So I started to think about, how can I share this better with people? How can we sort of understand the genesis of where some of this is coming from? And this, so something you should not do before a keynote also is listen in on a session with Angela Davis, which I had the fortune to do, and also see the musical Hamilton. And that will just sort of change everything that you're thinking about and how you're going to talk about things. I wish I could wrap out the whole thing. But so Angela Davis says, our histories never unfold in isolation. We cannot truly tell what we consider to be our own histories without knowing the other stories. And often we discover that those stories are actually our own stories. This is a dialectical process that requires us to constantly retell our stories, to revisit them, retell them, and relaunch them. And I thought about, what is our collective story? A lot of times, especially in the US, but it's happened across the world, when people say Black Lives Matter, people will respond, but all lives matter. Now, saying Black Lives Matter doesn't mean that all lives matter, but it means that without understanding what Black folks need in order for our lives to matter, then all lives will never matter. So we have to kind of have that understanding. And I thought this is a good way to sort of think about this. So let's start with the diagnosis of drapetomania. Oh, yay. How early is it in the morning? And I'm going to go down this kind of road with you. But this is really important to think about, that this was a diagnosis that was considered a runaway slave syndrome. Of course, people know now this is pseudoscience, but imagine what people were thinking back in the 1800s. That, we have this doctor. A doctor is a person of prominence in the community who's saying things about enslaved Africans and what you need to do to keep them in bondage and keep them in this state, because they need to be in this state. At the end, it says they have only to be kept in this state, meaning, keep them away from each other, give them a small fire, treat them like children, in other words, and that will cure them from running away. And that wasn't all he said. So he also diagnosed, and I'm not even going to pronounce this, but he also diagnosed, I don't even know how to pronounce it, Dysthesia, Ethiopia, blah, blah, I don't know. But the point of it is basically it was called rascality or laziness. And what Dr. Cartwright had determined is that this is for people who, for African Americans, again, well, they weren't African Americans at the time, but for Africans who were enslaved, it is this lack of intelligence and having this skin insensitivity that's just peculiar to Black folk, right? Which is like, what is he talking about? And basically, he said that, that whipping could also cure this disorder. So we have being treated like children, we have whipping as ways in which people can be controlled because of the color of their skin, because of their stature in society, and a doctor giving these pronouncements and prognoses as well as diagnoses and treatment. So in the 17th and 18th century, the health of slaves and mental illness was the responsibility of the plantation owners. And those who survived harsh and cruel punishment were incarcerated in the plantation hothouses or dungeons. And I write this here, and I'm sorry, I use a lot of images because I will forget what it is I'm going to say. So I'm going to use a lot of imagery to kind of get through the presentation. But I use this because when I think of, people who are put in isolation, when I think of current hospitalization, and when people are removed from other folks and put in isolation, that it isn't too far removed from what happened in the 17th and 18th century. Of course, it's not hothouses or dungeons, but it is this sense of incarceration and carceral state. So the important thing here, and I'm going to read this whole thing because I just think it's too important. And this comes from a paper written by Fred Hickling, who passed away. This year has been a really tough year of people passing away, great leaders. But the concept of involuntary commitment, custodialization, and compulsory detention for patients with acute mental illness is a product of modern European civilization, and to this day underpins much of the contemporary European mental health agenda. The custodial phase of world psychiatry began with the asylumization of the globe by European colonial political epoch and has led to the current mental health system in the West and similar systems in many parts of the world. So you see why we have to start with enslavement, and from enslavement of Black and brown bodies, now it is the way in which people are controlled, not just Black folk, but everybody. That's why we have to start at the beginning and tell our stories. So I also, we're going to kind of skip ahead a little bit because I think those stories are so powerful and still with us in the nature of what was socially constructed. So we think of the 1920s and the 1950s. Women had gone back to work. It's the end of the war, and there's more. Women have to take on several roles. They have to work. They have to take care of children. They still have to take care of the household. So in 1952 is the first DSM. Yeah, I'm going to bring it up, the DSM. In 1952, and I'm not a clinician, I'm not a diagnostician, just so you guys know. So in 1952, there was a focus on biological lesions and early life conflicts and reactions due to personality or psychological or social and environmental or biological stressors. And so in 1952, in the DSM, and that is actually, if you go to the American Psychiatric Association on the executive level floor, there is a copy of the first DSM, and look how tiny it is. Look at that. Look how tiny it is. When I first saw it, I was like, wait a minute. The DSM now is this huge, massive thing. And here's this little teeny tiny thing from 1952. But in it, they have a schizophrenia reaction. So it was a collection of psychotic and neurotic symptoms thought to afflict women who struggled with their role of domesticity. So I've just told you a little bit of the cultural context of that time. And here are ads for, and of course, this is the advent of new medications. So here's some ads that are actually in the annals of, I want to call it the annals, but I know that's not what it is, the annals of medicine. And because there wasn't direct to consumer advertising, but the advertising went to the doctors. And so this is what doctors are seeing and thinking and contextualizing about women. So Thorazine, we know what Thorazine is. And for the prompt and sustained relief from severe and emotional distress, use Thorazine. And here's this woman just looking, I don't know, she's just having a bad day, right? So let's go on. So here's one for Serpacil.
The emotional threshold against everyday stressors provides tranquility for patients who, without some help, are incapable of dealing calmly with the daily pileup of everyday stressful situations.
Okay, so whoops, sorry, my bad. I hope you all could hear that. Could you hear that? Could you hear the ad? Okay, so, well, there you go. The poor woman. She can't handle her kid who's running around. She can't vacuum. So she deserves to have Serpacil. Really? Does she? Like, let's think about this for a second. If this ad were today, who would the ad be geared toward? Would it be the kid for ADHD? So again, cultural context matters. And the next, the woman is, and I couldn't get the audio to play on this one, but the ad is for, I think it's for Dexedrine. And it says, why is this woman tired? She may be tired for either of two reasons. And one is, oh, she's just mentally done in and basically look at her, look at all those dishes on the sink, and she just can't even take it another moment. And I'm like, where is her husband? Where, husband, go get her a maid, go get her a dishwasher. Like, seriously, why does she need to take Dexedrine? Because she can't do the dishes. But that's what the messaging is because of the social context. And this is the message that's going to the medical community. So if a woman is really struggling and all she wants to do is talk about her daily struggles, in the mind of somebody who's hearing that, who's seen this picture, it may make an association. Oh, let me see if I should diagnose and then prescribe some medication of Dexedrine. This poor woman, she's got anxiety complicated by depression. She just can't do the flowers for the party. So give her some Thoridex, take her up, take her down. It's really just this ridiculous notion when we think about it, but it's not a ridiculous notion because it's actually what has driven psychiatry. And here, this is for Hal Doll, and it's a whole 2-page spread. And basically, she's hospitalized. Look at her, in the sneakers, as if she had control of having no shoelaces in her sneakers. We know why she doesn't have shoelaces in her sneakers, but you give her some Hal Doll and look, now she's at home, and I guess her kid is still running around because the toys are on the floor. But for the most part, she's in her pumps. And if we saw her top part, I'm sure she would probably have on pearls. What was happening with Black women? I didn't see any Black women there. Well, there you go. Black women dealing with trauma, and we're suffering, and society's like, we'll help you. And how do we help? Oh, it's the strong Black woman, and they just give us a high five and let us drown. That was so before, and that is so today. So what was happening in the 60s and 70s? You all can kind of guess maybe some things as we go through this. Maybe you've heard me give this talk a little bit before, but if you want to write in the chat what you think is happening culturally in the 60s and 70s, go ahead and join in. So of course, during the 60s and 70s, it was the Vietnam War, civil rights movement. And this is when I was just coming back to the United States, and I have to tell you, seeing pictures of police with dogs and fire hoses still causes a reaction in me, especially when police came to pick me up when I was in psychiatric distress. I don't use extreme states, the term myself, extreme states, because I feel like every day of my life as a Black person is an extreme state. And that is a very dangerous place for me to be. But I can call it, being in distress, I think. But these kinds of images are still stuck in many, many people's minds, and why there's a fear of the police, of course. So what did ads look like at this time? So now, of course, we have the new DSM, we have DSM-2, and basically now we've kind of removed a lot of things. It's less culturally specific. It's more in line with the ICD, and it removes this reaction to stressors in the community, for example. And so now we have a new definition, if you will, of a schizophrenia paranoid type, and it's characterized by persecutory or grandiose delusions associated with hallucinations. The patients are hostile and aggressive, and quote unquote, his behavior seems to be consistent with his delusions. Well, and there you go. So now we've switched from focus primarily on white women. And if you read The Black Psychosis by is it Jonathan Metzl? Yes, Jonathan Metzl. He actually looked at the census in the hospitals at the time. And in the 50s, it was primarily, young housewives, young white women, and they were housewives. And then when you get into the 60s and 70s, though the census of the white women go down, and it increases by Black men. And I want you to take a look at this. And what does it communicate to you? So first, let's start with the picture. Pictures speak 1,000 words. So when you see the picture, what do you see? You can write it in the chat as I'm speaking, but first you see the language, assaultive and belligerent. And you have a fiery city behind the Black man. He's leaning forward in a very aggressive manner. His mouth is open, and he has a fist up. Now, supposedly this is the Black power fist, but it is not. The Black power fist never faces up what do you call it, palm forward to you. It always is palm out, because this is not aggressive, while your backside of your hand out is aggressive. It looks like you're going to punch someone. So what are you trying to do? You're trying to control him, and you're going to control him by giving him Hal Doll. During this time as well, Martin Luther King spoke to the American Psychological Association about creative maladjustment. And basically what he was saying is that, look, there is no way that people should be adjusted to societal ills. There is no way that people should be adjusted to structural problems and structural issues such as racism. And the only way that we can get through our lives is to be creatively maladjusted. And the only way that we can also, I think, work through a lot of these issues is also to be non-conforming and be creatively maladjusted. I know we use this term a lot in the mental health field. However, I'm not quite sure it's majority in the consumer survivor movement. You know, white folks have used the term, they've quoted Martin Luther King, but I don't think they really understand the depths of what it means to be creatively maladjusted and to do that every day of your life from the time you come out of your womb, not from the time you get a diagnosis. This is how we've had to live our lives from the day we came out of our womb. And my father says that it is in our DNA because he had to do it. My mom, as a Native American and Black woman, had to do it. My grandparents had to do it. So this is in our DNA to be creatively maladjusted. And I'm kind of proud to be that way. All right, this is pretty heavy, right? So every once in a while, I'll pop in something silly just to kind of lighten the load a little bit, because this is pretty heavy. So what would you say is the source of your stress, says one fish to the other, the therapist fish, as the big old cat is looming in the background, like duh, right? Okay, so one of the things that we have to think about when we're thinking about revolutionary change is not just the oppressive situations, which I've talked about, but also the oppression which is implanted in each one of us. And that's kind of where I had to really do a lot of learning and thinking and actually putting some dots together, because people weren't helping me with those dots. It was a lot of pathologizing, rather. So I needed to find somebody who could help me kind of understand what it was I was going through from a cultural context. I was very lucky. I had a fantastic psychiatrist finally, and you know, he could listen and kind of nod and affirm, but he couldn't really say, well, this is what it was like. So I asked somebody, where are the Black leaders in the consumer survivor movement? Where are they? I don't see them. I see a lot of us in the audience here when I go to conferences. I see a lot of African Americans. I see a lot of people who look like me. I see a lot of Black and brown people. When I go to recovery conferences, when I went to peer conferences, I never saw us up on stage. So really, I thought recovery wasn't for me. How could it be for me? Everybody on stage was in recovery and talking about it, and we were in the audience kind of sopping it up, waiting for our turn. So thanks to Dr. Ron Bassman, who I reached out to because he wrote an article about the next wave of the consumer survivor ex-patient movement. This was years ago. He introduced me to Miss Jackie McKinney. And this is the first person who I met who was a leader in the consumer survivor movement. I'm in LA and she's in Philadelphia, oddly, a block away from my parents. But I had never met her. And we are actually on the bus at St. Elizabeth's Hospital, where she was telling me how she was a patient there, how long she was a patient there, and how she was helping people as she was getting better while she was a patient. When she was discharged, the hospital asked her to come back because they recognized she had this wonderful gift to help and support people. So she was pointing out different places in the building. And then we went to the grave, the cemetery. And what was striking to me as they were giving us a tour of the cemetery is that, of course, we know that people are buried with numbers and no names. And sorry, this is a little, okay, it's a little hard for me because actually Jackie McKinney passed away. And she's the one who really helped me know that I could do this. My parents helped me know I could do it. They told me all the time, you could do whatever. There's nothing standing in your way. They told me from the day I was born. I got the diagnosis. They told me there is nothing that you cannot do, and we will support you to do that. When the doctor said, no way, she can't do this, she can't do that, my parents said, oh, hell no, she can do whatever she wants. And I'm very, very lucky to have that kind of support from my family. But your parents are supposed to say that, right? Well, most parents are supposed to say that. So when I met Jackie McKinney, it was this outside person who didn't know me who said it. Anyway, when we were at the cemetery, it was really striking that even in the cemetery, there was no dignity for Black and brown folks, that in the cemetery, they were segregated. They could be together in the hospital, but they were segregated at death. Like somehow our bones and our ashes are going to like F up white people. I don't know what they were thinking. I mean, it's just so ridiculous, but it is so true as to what happened. So I want to thank Miss Jackie McKinney for all of her work, and may she rest in power and paradise. I've always been interested in where some of the other consumer survivor voices. So in 2000, this is like really sad. I'm crying. What the hell? Okay, that's not supposed to happen, but it did. Okay, so I'm back. So in 2002, there was some work done by SAMHSA, the Substance Abuse and Mental Health Services Administration. And this was one of the series of papers that was written in our own voice, African American stories of oppression, survival, and recovery in the mental health system. You can access this document, and I think it's well worth reading, though it is from 2002. And it features his sort of an oral history of Pearl Ella Johnson, Ola Mae Clemens, and Quincy Boykins, just a few people that are named. And what it really talks about is the revolutionary act of self-love and demand for visibility for African-American psychiatric survivors. We're all now starting to notice, where are we? Who are we? How do we know who we are? And I get calls a lot where, I didn't even know you were Black. Sherelle Bellamy, Dr. Bellamy, I didn't even know you were Black. And I was like, oh my God, I didn't know you were Black either. Like, don't hide us from each other. We really do need to know who we are. We might, and at the end of the day, it's not like all Black people will like each other any more than all white people will like each other. But it's important for us to know who we are and what are we doing in this field and how can we help each other and also help everybody else as well. So Kelechi Obozo, who's written We've Been Too Patient, is actually starting to work on collecting more oral histories of African-American consumer survivors in the movement. And I decided, okay, I'm tired of everybody calling me and I can't collect everybody's story and it's just taking too long for me to introduce everybody to everybody. So I started a podcast called Unapologetically Black Unicorns, which again, captures the story primarily of people with lived experience who are people of color in order to, it is a bit of an oral history, but it's also to talk about what is the work that they're doing and how can we encourage other people to do that work. I recognize also that licensed providers, psychiatrists and psychologists are woefully underrepresented with Black and brown folks. So I actually interview lots of different folks and people like Pat Deegan, who works with extreme intention to ensure that she's inclusive in all of her work and all of her trainings. So she's actually one of the last people that I had on my podcast this past week. So now I'm getting it. Now I'm like, okay. So now my circles look completely different. And as I'm understanding some of the historical context, some of the structural issues, I am able to really advocate for myself around the things that I need and focus on those things such that my care team, which includes psychiatrists, psychologists, and peer supporters, now are able to engage with me on the things that are important: family, work, social connections. It's not that any of the symptoms, if you will, or the experiences may still sort of take me out, but it's still important for me, as people recognize, to be able to focus on family, work, social networks, etc., not to sit around and talk about what's the symptom, why the symptom, where did the symptom come from. That doesn't really work for me. What really works for me is to get back into those things that keep my mind very engaged and keep me engaged with people. Yeah, so what about that medication? I go to the pharmacy, you ask for the antidepressants, and what do I get? I get a puppy. Okay, I wish they would just pass out puppies. All right, that's just me being a little silly. All right, so what are some of the things that we need to think about? And this is from Dr. Ruth Shim and Dr. Sarah Vincent, Social Injustice and Mental Health. And really what we're talking about is understanding all of the structures and the barriers that can cause adverse mental health outcomes and the unfair and unjust distribution of opportunities. So, for example, homelessness, housing, food, transportation. We know about ACEs, adverse childhood experiences, discrimination, etc. All of these things create behavioral risk factors and psychological stress responses and psychosocial stress. And so our work needs to be at the policy level as well as at the social norms level, because there's social norms here. And I'm worried about what's going to happen in the crisis reform space in 988. The public is not going to call 988, even if they, okay, what is 988? Let me back up. My bad. 988 is the new mental health crisis number in the United States. Previously, or as of in July of this year, it will be on for the nation. And what we were dialing before was the National Suicide Prevention Lifeline. If anybody knows the National Suicide Prevention Lifeline, put it in the chat. I can't tell you what it is because I have to have it written down. It's too many numbers. But 988, ooh, that's easy, like 911. It's very easy to remember. So if anybody's from the UK and watches the IT crowd, they have a episode about the crisis, the hotline number, and it goes on and on and on and on and on. And that's what our number is like. So my fear about 988 is that if a Black man is seen as aggressive or seen in the street naked or seen talking to himself and trying to figure things out, we know what has happened. We have evidence of what has happened with Walter Wallace, for example, or Ricardo Munoz. We know what has happened. So what is going to make people dial 988? They're still going to dial 911. And the operator, even though they may hear mental health conditions, may have their own bias and go ahead and contact the police. So we need to work on the social norms as well as the public policies. A lot of these things are structural and cultural. So a lot of times we work on cultural competencies and we don't think about some of the structural competencies. So cultural competencies is, as it says here, seeing and honoring the person as a woman and as a woman of color. She should be African-American, she could be whatever. She could be Latino, Latinx, who knows. But the point is, you see, she has to run the same race. She's starting at the same starting point as the white man, but clearly she has a lot of barriers and structures that will get in her way, not get in her way, but that she has to contend with to get to the finish line. And so we need to work on the structural issues and seeing and dismantling the barriers in front of people of color, in front of people given diagnoses of mental health conditions, because there is no way that this is really going to work. And in the United States, of course, we have a separate system for people who are given diagnoses that by policy are considered serious mental illness. Again, very intentional language I'm using here. There is no such thing as a serious mental illness. It was created in order to figure out who goes into the public mental health system by nature of three things: disability, disability, duration, and sorry, I forgot what the last one was. Income, right? So you have to be in poverty, right? So think about that. You have to be in poverty. That's kind of problematic. How do you get well if you're in poverty? Poverty, that's part of one of the social determinants of health. But the point is that serious mental illness was constructed so that there could be a mechanism to determine who qualifies for public mental health services and who doesn't. So saying that a person has or has been given a serious mental illness, it doesn't even make sense. So that is a structural issue that I hope one day we can look at and actually dismantle. The other thing that I like to think about, and love my elephant here, is how differently some of us experience the very same issue. So it's just like the blind man who touched the elephant, and one's touching the left ear, one's touching the right ear, one's touching the tusk, and they all think they're touching the thing, but they're actually only touching one part of the thing, and their experience is valid because they're touching and experiencing that part. That's why for me, it's really, really important that we involve as many people who are working on this issue and we work together. So when I think about involving more people of color, more people with lived experience, by training, I'm an industrial organizational psychologist. And so I like to think about things that are done in around organizational structures and change management, things like that. So here we've taken something around lived experience initiated partnerships in which everything is co-done, and I call it the Coco. So there's co-production, there's co-design, co-planning, co-delivery, co-evaluation. In order to do that, we have to prioritize our relationships with people with lived experience, with people of lived experience who are people of color, people with lived experience who are LGBTQ. We have to think of all of those intersectionalities. We need to help people build capacity. We can't say, oh, well, they can't do it because they don't know how. Well, then you have to teach them how, right? Bring them alongside and have them learn how to do some of this work with us. We have to share power. Nobody gets to have the power here. And then we need to use our participatory means. I hope I'm not speaking to the choir on a lot of this. So, and then this, I think, is a great graphic from the Global Mental Health Peer Network, and you can access this at www.gmhpn.org. And it actually lays out some different ideas about ways in which you could do this Coco kind of thing, this co-production. And all I add in here is think of who is not at the table. Who are you missing? Who's not there? If there are Black folk in your neighborhood and you don't have Black folk at the table, that's sort of problematic, right? So we need to think about who's missing and work towards ensuring they are part of some of these initiatives that we're working on, if it's policy, research, services, workforce. And here, workforce is in service delivery. People with lived experience are working within our mental health complex, if you will, and they have all sorts of rules. Some of them just are not out, but certainly we could think about, having a person with lived experience who's out and using that lived experience in an HR department. What difference would that make in our hiring practices? All right, so you can use something like this, and this is a great way to think about where am I and where do I want to be? Where does my organization and where does my organization or agency want to be? The goal is to be at the top, which is the lived experience contributing at all levels, especially lived experience of people of color. So this is the lived experience engaged organizational ladder, and it was called the Consumer Organizational Ladder by Hart, where when UNICEF was trying to better define how they were going to involve the people that they were serving in design, implementation, and evaluation. They thought of all the different levels from marketing campaigns, which is kind of telling your personal story, tokenism, meaning, having one person do one thing and it wasn't really very impactful, job tokenism, involving people but not having any input. Separate but equal sometimes is necessary, but also be careful that separate but equal can sometimes mean it's not equal. Think again about the community mental health compared to FQHCs, which are sort of public health primary care, if you will, separate, and we are seriously not equal in the public mental health system. So you want to move to input and influence. There's no leadership, but you really want to be up in this green area. So you can figure out, where am I now in any of these? Why am I there in this particular area? And where do I want to be? And how do I get there? And I love this because I think this is why I don't do land acknowledgements anymore, because it's not enough to say that I'm on the land of the Tongva and Chumash people here in Los Angeles, because it is their land. I am on it, but I'm not giving it back. So why am I saying that I'm on it in some kind of way? It doesn't really resonate. And in my nation, we don't actually appreciate the land acknowledgements. Other people do, so I try to honor what other people want, but in our nation, we don't do it. So instead of showing me your diversity statement, show me your hiring data, discrimination claim stats, salary tables, retention numbers, diversity policies, and public actions against racism. So we don't want performative allyship. And I'm really going to stress this because during the conference yesterday, people were asking, well, what are the demographics? And some of the panelists couldn't say. Now, either it might not be something they collect, but even anecdotally, there really wasn't a lot of understanding of what are the demographics as far as race and ethnicity. I found that sort of sad. and I think, I was thinking back to NAMI, for all it is and whatever, I'm not even worried about that we made a concerted effort. And when people had to put in for workshops and panels, they actually had to talk about how they were going to address race, culture, LGBT in order for it to be reviewed and then accepted as a possible presentation. So here's another thing that you might want to look at. And then these are just some tools. This is from the Bridge Housing. And basically it talks about how do we traditionally build strategies for collaboration? What are some examples of that? Secondarily, what are some of the challenges? So when we're involving people of color who may not have been involved before, you're going to run into trauma challenges. They're not going to trust. I didn't trust people, right? It might not be something that would happen quickly. We don't sometimes believe that our best interests are really at heart. So there are 4 guiding principles in order to work through some of the barriers, which is first, do no harm, and making sure there's developing relationships over time with people. So this may not happen tomorrow. As a matter of fact, Bridge Housing says sometimes it takes generations. You're trying to do no harm, build acceptance, build community empowerment, and then a reflective process of how did this go? What could we be doing better? Sure, some of this must fit in with sort of the dialogical processes, which I don't know about. I'm not a practitioner, but hopefully it aligns. So I think, ooh, yay. Good timing. So this was really supposed to be about the power of words. So I want us to also understand the word courage and the our origins of the word courage. A lot of times people with lived experience are said, oh, it's so courageous of you to speak up, which feels a little bit like inspiration porn. I don't know. That's what I've heard, and it does feel like that way to me. But I think we all have the ability to be courageous here. We all have the ability to speak honestly and openly about who we are, about what we're feeling, about our experiences, whether they're good or bad, in order for us to be courageous. It's not heroic. It's something that we can all do. And I hope we can all do this together. So thank you very much for letting me have this time with you and sharing some of my thoughts with you. Thank you.